Hi, and welcome to AAHPO's American Armenian Health Professional TV Health Program. Today we have an important topic, and it is ovarian cancer. And we have Dr. Vaagn Andikyan, who is Clinical Assistant Professor at Western Connecticut Medical Group and practices Danbury and Norwalk Hospitals. Dr. Andikyan, welcome to our program.
Thank you very much.
Your subspecialty is gynecological oncology, and I'm sure you're getting a lot of patients on that. How often do you see ovarian cancer in your practice?
It's a very common problem. Also, the incidence is stable in United States, but I see every week 1 or 2 patients with newly diagnosed ovarian cancer.
What are the signs and symptoms they come? Obviously, they go to either primary care or gynecologist first, and they're referred to you. But usually, what are the signs and symptoms that they come with?
Ovarian cancer, unfortunately, doesn't have obvious signs and symptoms. The symptoms that ovarian cancer presents are vague. And most of the time, patients have abdominal pain, bloating, and those symptoms could be unspecific and could be related to many other problems.
Sometimes, gynecologists probably or primary care physicians, they do pap smears, can detect some cells that it might be indicative of an ovarian cancer in the pap smear?
On pap smear, no.
No.
What could happen if the patient has some imaging for some other reasons?
Yes.
And that time will ovarian mass diagnose early, and that triggers appropriate evaluation with medical providers. In that case, we may catch up with early diagnosis of ovarian cancer. That's a possibility.
Right.
Another possibility, if the patient had a family history of ovarian cancer, those patients have more scrutinely screened for ovarian cancer, and we can catch the diagnosis early.
Family history is very important. If somebody has family history of ovarian cancer, yes. How about if somebody has a history of breast cancer in the family, either mother or the immediate family, or they themselves have breast cancer? What is the possibility that they can develop ovarian cancer? The risk is higher?
Not necessarily for all breast cancer patients. Here we're touching the topic of BRCA mutation. Yes. 10 to 20% of ovarian cancer has a genetic background, and there are mutations with different genes associated with both breast and ovarian cancer.
Is it usually familial? Sometimes if their mothers have it or grandparents have it, or?
Yes, the family history is suggestive of ovarian or breast cancer. We screen those patients and will for genetic mutation, in particular BRCA1 and BRCA2 mutation. And BRCA1 mutation is associated with 70% risk of breast cancer and 40% risk of ovarian. In BRCA2, it's about the same, 50–70% of breast and about 15–20% of ovarian cancer.
So now the patient comes in and has a high risk. You did the test and it's BRCA positive. So what is from there on? Now we do the CAT scan, MRI to see if they have it or not. If they don't have anything on the CAT scan or MRI, what is the recommendation for those patients that they have positive BRCA?
The situation, we tailor the treatment based on the age. The recommendation is to perform a risk-reducing bilateral salpingo-oophorectomy for patients.
That means that taking both ovaries and salpinx out?
Yes, after completion of childbearing.
Okay.
And usually it's age 35 to 40, depends on the personal desire and family request. Those patients may undergo risk-reducing procedures, and that will decrease both the risk of breast and ovarian cancer as well.
So when they have ovaries taken out, it decreases the risk of breast cancer too?
Correct.
So those people do not need to have a breast removed?
Not necessarily. So they still need the breast. Breast issue has to be addressed separately as well. Right. But in general,
continuous follow-up or
mastectomy.
So those people are recommended that they might have a mastectomy
as well.
How about somebody comes in with BRCA positive breast cancer and they have breast removed? What do we do for the ovaries?
So those are the patient you consult about the importance of removing all ovaries and tubes as well, because ovarian cancer It's a very aggressive disease, and prevention is probably the best strategy for those patients.
So we are talking about obviously BRCA positive patients of breast cancer. Some patients obviously they don't have BRCA positive, so we're not talking about those patients. We're talking about only BRCA positive patients.
Yes,
does it
correct.
make difference BRCA 1 or 2 in terms of breast cancer and ovary removal?
In BRCA 2 patients, incidence of ovarian cancer is slightly lower. And usually onset of ovarian cancer is at the later age.
Now let's say they decided that they will have surgery. So obviously there's a minimally invasive surgery, there's robotic surgery. Let's talk about minimally invasive surgery. What kind of surgery is that?
Minimal invasive surgery, it's a surgery through the small incision. It's a traditional laparoscopy or robotic surgery. We make a small incision in an abdominal wall. We introduce a camera inside the abdominal cavity. We insufflate abdomen with a gas that gives us a room for maneuvers. We place additional instruments into the abdominal cavity and take out the tissue through the small incision. What it does, it helps patient with postoperative recovery. Pain is significantly less. The patient may go home same day or next day compared to the open procedures.
So if patient is expected to have ovarian cancer, what kind of workup that you do prior surgery?
We start from history, making sure that what's her symptoms, and depending on the symptoms we decide about the imaging. Every patient gets a CAT scan of abdomen and pelvis. We would like to get the imaging of chest. It's either chest X-ray or CAT scan.
Do they get any bone scan?
No, and typically not, unless a patient has a severe back pain or some symptoms suggestive of the spread into the bony tissues. But typically ovarian cancer doesn't
go to the bony tissue.
Yes.
What is the staging? How do you stage the ovarian cancer?
Staging of ovarian cancer is surgical. So we remove all this affected tissue. We perform debulking surgery. In early stage disease, we perform staging surgery. Depending on the amount of disease we see in the surgery, the patient could be stage 1, 2, 3, 4. In general, stage 1, that means that disease is only in ovaries. Stage 2, the disease spread out within the pelvis, which is the lower part of our abdomen. And the stage 3, it's affecting intra-abdominal organs, spleen, liver, bowel, intestine, or lymph nodes. And stage 4, it's extension into the soft part of the liver, not just the surface, but within the liver or lungs.
Chemotherapy for every stage, or chemotherapy is only stage 2, 3, 4?
Chemotherapy typically for all stages, with few exceptions. Stage 1 disease, where a well-differentiated tumor could be absorbed. But it's a minor group of minor subset of the patient with ovarian cancer.
Really are stage 2, 3, 4, and they need the chemotherapy. How long is the chemotherapy?
Chemotherapy is typically 6 cycles, and that's administered intraperitoneal or intravenous. We have different regimens, depends on the biology of disease, amount of residual disease, and patient's symptoms in terms of how she tolerates the chemotherapy with one drug versus the other. But typically those patients treated with platinum-based chemotherapy.
5-year follow-up is necessary, especially because it's important in terms of the survival.
Yes.
What's 5-year survival for stage 1 on?
So for stage 1 disease, we're talking about 80–90%.
5-year survival.
Yes. For stage 2, 70. Stage 3, 40–60%, and it depends on the amount of residual disease. Those patients who underwent good surgery in terms of the all cancer is taken care of and removed, those patients have the best outcomes. And stage 4 disease, the survival in 25–30% range.
Dr. Andikyan, thank you very much for this enlightening information. Hopefully we'll see you in another program.
Thank you very much for having me here.
Now it's time for this week's article, and it relates to pregnant ladies. It is maternal vitamin D concentration during pregnancy and birth outcomes. Vitamin D deficiency is common and related to various non-communicable diseases. Vitamin D deficiency during pregnancy may affect fetal outcomes. Suboptimal vitamin D concentration may affect placental function as well as fetal growth and development. Many studies from USA, Holland, and China have reported that low maternal vitamin D levels during pregnancy are associated with low weight at birth and small for gestational age. Recently, researchers from Holland and Australia examined whether maternal vitamin D concentration in pregnancy affect fetal growth patterns. They measured vitamin D concentration continuously starting 20 weeks of pregnancy, and fetal head circumference, body length, and weight were estimated with repeated ultrasounds. In this study, 53% of all pregnant mothers had vitamin D deficiency. In pregnant mothers with vitamin D levels less than 50 nanomole per liter was associated with 17% of preterm birth and 22% of small size for gestational age. In conclusion, this study findings suggest that second trimester low maternal vitamin D levels were associated with third trimester fetal growth restriction and increased risk of preterm birth, low birth weight, and small size for gestational age. Normal vitamin D level is between 30 and 100 nanomole liter. If you are pregnant or planning to get pregnant, get your vitamin D level measured and make sure that your vitamin D level is more than 50 nanomole per liter during your pregnancy. Good health is precious and priceless. Keep informed. For up-to-date medical information, visit AAHPO's website, aahpo.org. I'm Dr. Ohan Karatoprak. Until next program, so long.